Good morning, everybody. We are welcoming you at our first online Zoom training. And we're excited for you guys to come in and be questions. Welcome to our first online Zoom training. And today is February 27th, 2025. Our main topic is emergencies in primary care. And we are so fortunate, blessed, and honored to have our very own one of our board members for Qhsc, and she has been there from the beginning, and we are so proud of her for all the accomplishment. Her name is Mrs. Anne Schneider Zollman. She is just got her education, and I know she's going to give her information a little bit more, but she's a nurse practitioner who has a vast experience of all the areas that you can ask for. And then, so the first topic she decided to come and share with you guys today is emergencies in primary care. We're going to ask you to be able to ask those questions and then put it in the chat so I can read in between when she's presenting. That's usually just allow us to have a nice, smooth flow of the presentation. And then if the questions is related to what content she's presenting, then I'll be able to interject and add that question. Or if the questions are asked and then you guys have great questions, but we can cover during this training, we're gonna host another one, a follow-up from this one to hear your feedback and then to address those questions. So don't be shy. And if you have to ask a question in Swahili, please go ahead and ask that question, and then we try to translate for her so she'll be able to answer if the time permits. But again, bring those questions, send the question in the message or the chat, if possible. If you don't have, you are able to send a message to the chat, you can send it to the Qhsc group if you are in there. If not, send in the email. So if I'm able to track it during the training, then you'll be able to give it to our presenter. So we are so excited and blessed to have our very own and share her knowledge with you guys in Tanzania. So we want to know what Tanzania does during emergencies, especially in primary care, and we want to be able to get that information included in this presentation. So ask those questions so then we can address those things. As I said, if we have so many questions, definitely we're going to host the second one, a follow-up. So don't worry about it. Say, oh, my question was not answered. We will answer it either today or in the next training. So without delaying, I'm going to welcome our very own Mrs. Anne Zollman. Go for it.
Good morning, everyone. Thank you so much for joining us today. I'm very excited about this. As Harriet said, my name is Anne Schneider Zollman. I'm a nurse practitioner in Southern Indiana. I did get the privilege of working with Harriet in Cincinnati. And like she said, I've been working with Qhsc from the beginning. I did have to take a little break when I was in NP school and when my daughter is born, but now I am back and ready to assist in any way that I can. And like she said, I want this to be a very interactive presentation. I'm going to be asking a lot of questions. So feel free to answer or type your answers in the chat. And obviously, you guys are the experts on where you work and what is presenting to your clinics and to your emergency rooms. So I can only speak from my perspective. So I'm really interested in hearing your perspective and things that are important to you, medical conditions that you want to have more Qhsc to do more presentations on. So just feel free to type in the chat or speak up. All right, so let's begin. Okay, so first, I just want to review the objectives. As you can see, we're going to identify signs and symptoms of these emergencies that could present to an outpatient clinic. So these are heart attack, stroke, sepsis, some common injuries. Today, I'm going to be talking about like a dog bite. We see that frequently here, an animal bite, and then some allergic reactions. We're also going to be discussing appropriate initial actions and treatments. And I would like to just highlight that this list is not all encompassing. There are countless other emergencies that could present, but these are just some of like the most common um, emergencies that you might see presenting. Um, and then also, these are medical conditions that could be easily confused or easily misdiagnosed. Okay. Um, so obviously the information that's presented today can benefit everyone. It's geared more towards patients that are presenting to an outpatient clinic. Um, these are patients that are potentially known to you, that you're familiar with their medical history. Um, so it's important to really pay attention to a patient's medical history. And we'll see that throughout this presentation, how medical history can play a role in aiding our diagnosis. Um, okay. I don't know if that was a question or.
No, I think they needed to mute, but they didn't mute.
Oh, okay. Got it. Thanks. Okay. All right. So now let's get into the first case scenario. So I learn really well through case scenarios. Um, so I'm going to just read this off and ask a few questions about this situation. So this patient is a 67-year-old female. She's presenting to you today. Her past medical history includes hypertension, type 2 diabetes, obesity, and probably some hyperlipidemia. She has coronary artery disease. She states that she often forgets to take her medications. So today she is complaining of some epigastric pain, potentially some nausea, some GERD-like symptoms, generalized fatigue, and then she's also having some pain in her upper back. She states that these symptoms began yesterday, and she has experienced similar symptoms before. She's taken some antacids with some relief previously. Um, she also states she was rearranging some furniture a few days ago, and that's how she thinks she hurt her back. So what should we be concerned with today? And what do we need to do with this patient to determine what's going on with her?
Okay,
And
if
if you
you
want to type it,
Can we ask the question in Swahili, please?
good idea.
let me see. Kama mnavyoona alivyo present kwenye hii case, swali ambalo alikuwa anauliza ni kwamba amesema hizo symptoms mgonjwa alizonazo, I mean hypertension, diabetes. I think you guys that you unajua hata Kiswahili mnatumia the same thing. Angalia tu hizo symptoms alizonazo. Je, unaweza kufikiri kwamba tatizo lake ni nini? Unaona? Kwa hiyo ndio maana anauliza kwamba je, ukianza kusema mtu amekwambia kwamba alikuwa anafanya shughuli ananyanyua vifaa nyumbani au hizo furniture za siku chache zilizopita, alafu sasa mgongo wake unauma, lakini ana hizo symptoms zingine au ana history hiyo nyingine. Je, unafikiri mgonjwa na tatizo lake ni nini? Ndio anachouliza hapo kwamba kwa hiyo inabidi utafute kind of like a differential diagnosis, what exactly is happening there. Kama kuna mtu anaweza akajibu. Kumbuka kwamba wote tunajifunza, hata kama ukisema kitu ambacho maybe sio sahihi au ulifikiria tofauti, ni sawa. Wote tunataka kujifunza. Kwa hiyo share your opinion ili tuweze kujifunza wote. So mimi naangalia hapa kwenye chat. I'm waiting for people to say, oh, if you are able to unmute yourself and answer quickly, that would be great. Just give short and sweet answers. That would be great. I'm gonna give it at least like 30 seconds. People jump in and say something. Anybody?
And it's okay too if people just want to like type in the chat and, you know, I know it can be uh difficult to kind of unmute and then mute yourself again and stuff.
Okay,
Um,
Miss Khalid said coronary arterial disease, CAD.
mm,
Miss Khalid, can you share your response? Nani ukijibu kwenye Zoom or you? And we have people from Police Tabora and from Georgia. Okay. Anybody? I mean, Miss Khalid, do you want to say anything about that CAD? But that's part of the history.
mhm.
Go ahead. Maybe they're trying to figure it out, then be able to answer.
Yeah, absolutely. Okay, so when we're thinking about this patient, some potential diagnoses that we can think of, because her symptoms are not really extremely specific, but we can think of, GERD, cholecystitis. She might have some cervical disc disease because of the back pain or even a muscle strain. Um, so for this patient, because of her medical history, her uncontrolled hypertension, uncontrolled diabetes, um, the coronary artery disease, it would be prudent for us to go ahead and get an EKG. Um, and that does reveal for this patient ST segment elevation. So she's having a STEMI. Um, so when we typically think of a heart attack, we think of, the traditional left arm pain that's radiating down your arm, shortness of breath, sweating, things like that. Well, those are all symptoms that males present with. Females present differently for heart attacks. And so that's something important to remember how different patients will present with the same disease. And that is why getting that medical history is so crucial. So then our initial treatment, and this is sort of like in an outpatient setting that we're thinking about, should include 325 milligrams of aspirin. And then there are other things that we can do for this patient, but that requires more extensive treatment. And so she should go to the emergency room and be treated there with some nitroglycerin, morphine, things like that. But it's just important to remember how that medical history plays such an important role. All right, so now we have um, a 35-year-old male with no significant medical history. He's pretty healthy. He comes in today to see us with an acute onset of right-sided facial droop, poor right eye closure, significant watering of the right eye, and some impaired speech. And his wife is with him, and she states that he was normal when they went to sleep last night. So we don't really know when this event occurred. It's important to always, when a patient presents with these types of symptoms, to get the last known normal. And so this could be, you know, 8 o'clock in the morning. His last known normal might be 10 p.m. We don't know specifically the time of the last known normal. But his wife also mentioned that he is recovering from an upper respiratory infection. So any thoughts on this patient, what his presentation leads us to believe, or some differential diagnoses? You can type it in the chat too if you want to.
Just to kurudia hicho kisema kwamba huyu mgonjwa ambaye ni miaka 35 mwanaume hana history ambayo, yani hana medical history ambazo zinamsumbua kabla ya kuja hapa leo kwenye clinic, lakini ana hiyo yani kuna kitu kimeanza, ana upande wa kulia una hauko sawa na upande wa kushoto, na alafu macho hawezi kuona vizuri, hawezi kufunga nani upande mmoja au kuna maji yanatokeza kwenye jichafu, hawezi kuongea vizuri. Kwa hiyo maana hata jinsi anavyoongea imebadilika, lakini sasa mke wake ndo ambaye anasema kwamba alikuwa yani yuko sawa tu usiku uliopita. Sasa ni vitu gani ambavyo kwa unaanza kufikiria na saizi anapona kutoka kwenye nani hiyo upper respiratory, kama mtanajua what is upper respiratory. Sasa anauliza kwamba unafikiri kwamba atakuwa na tatizo gani huyo mgonjwa aliyefika huyo mwenye symptoms hizo hapo zimetajwa? Oh, Miss Khalid, she said it probably Bailey's palsy, and then Mr. Oscar said CVA.
Excellent, excellent. So that is perfect. So those are the differential diagnoses exactly that I would think of when this patient is presenting. So yes, we should always, when a patient presents like this, we should always be concerned for a stroke, because that is definitely a medical emergency. But this patient doesn't have the extremity weakness, no difficulty walking. And so I kind of had the case scenario be a little bit more vague, just so we could have both of those differential diagnoses. So as exactly hit it nail on the head, it's Bell's palsy. And that is also why our medical history plays such a crucial role in our diagnosis, because the peak incidence for Bell's palsy is 20 to 40-year-olds, and it disproportionately affects people with upper respiratory infections, which is a really interesting finding. So Bell's palsy, while it's very, it can be very debilitating, it can be very concerning for the patient. It's not a true medical emergency and can be treated with some high-dose steroids, while a CVA is going to potentially cause lifelong debility. And that's also why, and I left out vital signs off of that case scenario because that I feel like it would have given it away. But that's why we want to really pay attention to a patient's vital signs, medical history. But excellent. Thank you very much for that input.
One more comment from Boaz Mliwa. I think he did echo what you just said. It can be stroke or diagnosed by Bell's palsy.
Mm-hmm.
So you guys are getting great.
Yes, absolutely. I thought I was being tricky, but I wasn't.
They found out.
Right. All right. So this patient is you're just kind of returning phone calls in between patients, reviewing a message from the mother of your 2-month-old patient. She said to her baby, who was born at 36 weeks and was considered low birth weight, has been sleeping more than normal, kind of feels warm to the touch. She took the infant's temperature rectally and noted that it was 100.4 degrees Fahrenheit. This baby doesn't seem too interested in breastfeeding, just kind of sleepy, but not overly fussy. She's wondering if she should make an appointment, bring the baby into the emergency room, or just give the baby some Tylenol and wait and see. So for this patient, what do you think we should do? Is this a patient who you would advise, should they come to the emergency room right away? Should we just give them maybe an antipyretic, see what happens, wait until tomorrow? What do you guys think about this patient.
Okay, let me summarize quick for them. So anasema kwamba je, either unarudisha simu ya wagonjwa, kuna mtu anakupigia simu kukuuliza kwamba kukuambia kwamba ana tatizo, ameacha message afu unabidi kujibu. Kwamba ukiona hiyo message anasema na mtoto ambaye ni miezi miwili, afu huyo mama anakuambia kwamba mtoto alizaliwa na wiki 36, kwa hiyo alikuwa ni premature, ambayo ni low birth weight also. Kwa hiyo alikuwa premature na baada alikuwa ni low birth, na mimi uzito kidogo kuliko nani anavyotakiwa. Alafu mtoto amekuwa kwamba mtoto amekuwa silipo yani zaidi ya ambavyo expected mama anavyofikiria, na mtoto anafeel yani anakuwa na joto kidogo kuliko kawaida. Alafu nasema umechukua temperature ya mtoto alafu ukaona kwamba temperature ni 100.4. Alafu najua Tanzania mnatumia centigrade sinatumia Fahrenheit ambayo
I can translate it or I can convert it really quick. Hang
I
on.
think it's like 38 something.
Yeah, let me.
We have a test. 100.4 Fahrenheit. What is it in centigrade? Okay, and the baby does not seem interested. I mean, mtoto hataki kunyonya kwa sababu anajisikia vibaya au anaumwa hivyo hataki kunyonya. Sasa unaanza kufikiria kwamba je, umpeleke mtoto aende kuona na daktari au unampa dawa ya nani? Tylenol. Unajua Tanzania mnatoa Panadol. Je, unamshauri mama ampe dawa hiyo ya Tylenol au ampeleke mtoto emergency au afanyeje? Usia wako ni nini? Yani advice yako ni nini kwa huyo mama? That's what she's asking. Anybody? That's the answer.
Yeah, it's 38. I just looked it up. It's 38. Sorry.
No, that's okay. But I was thinking like anything required, yes. Okay, so people from Saulo Kapala, from Songea Police Dispensary, welcome. Thank you guys for letting us know where you're coming from, which hospital. It helps us for follow-up. If we have any questions regarding hospitals, or we want to be able to discuss something specific from your hospital, it's great for us to know how many people from different hospital came. So this is great. Thank you for letting us know. And Ronald Paris said it's 37.7. So I think, yeah, 100.4 usually is 38 something. Okay, go ahead, Annie. Because I was waiting for the response. What should we do with this mom and that baby? Oh, so Boaz Mliwa said, expose the child. If won't respond, bring the child to the hospital for investigation and further management. And then Khalid said, first expose the baby and wait. Then if temperature not going down, give syrup, paracetamol, I think it's PCT, I think it's paracetamol. So they're trying to like undress the baby and then see if the temperature is going to drop down. Stephanie Kisaka said, make an appointment of sending a baby back to hospital as she might need closer checkup. And this is from Stephen Tuala Hospital. Thank you. And then Ronald Paris, she should take her to the hospital since fever followed by inability to breastfeeding might be sepsis. Okay, Ronald Paris.
Yes. Excellent. Excellent. Oh, these are wonderful responses. I'm loving it so much. Yes. So this baby, so there's several risk factors for this baby. We're concerned for sepsis, absolutely, because this is a preterm baby, low birth weight, and in an infant that is less than 3 months old, any fever of 100.4 degrees Fahrenheit or 38 degrees Celsius, we would be thinking sepsis. And that's why I included an infant in the case scenario, because their symptoms are so less extreme than a adult that presents with sepsis. So an adult that presents with sepsis, you're going to see a reaction with their vital signs. They're going to have a fever. They're going to be able to express to you that they're feeling really terrible. But an infant, you might see a little bit of poor feeding. They might not be very fussy. They might just be a little bit lethargic. So it's easy to overlook the risk factors for an infant. Um, so absolutely, this patient should be taken to the emergency room for intravenous antibiotics because we are concerned because of the preterm low birth weight and the um, decreased want to feed. So excellent responses. Thank you so much for participating. All right.
Asani Shire from Kagera Police Line Dispensary, welcome. And then Boaz Mlivo from Katavi. Very good. Samsung, so that's Shukuru Nyagiru, Tanzania Police. Oh, very good. Welcome, everybody. Thank you. Go ahead.
Excellent. Thank you, guys. Okay, so this scenario we have is a 30-year-old male presents to your clinic. They had a dog bite on their hand. So the dog bite is greater than 24 hours old. He did wash the wound with soap and water, but today has noticed that it's pretty swollen. Probably pretty painful. He has no significant medical history or allergies. So, what would we do for this patient? And should we close this wound up?
So anavyosema mgonjwa huyu AC ana miaka 30, ni mwanaume ambaye anakuja kwenye kliniki yako, anasema aliumwa na mbwa almost masaa 24 yaliyopita. Sasa na kwenye hapo kidonda alipoumwa aliosha na sabuni na maji. Sasa lakini leo anaona kwamba pale ambapo kuna hicho kidonda kuna ni pamevimba. Sasa unafikiri kwamba na hana yani previous medical history, hana hivyo vitu au hana allergies. Sasa unafikiri kwamba ni nini kinatokea kwa huyo mgonjwa? Or did you say, oh, should we close them? Anasema kwamba je, hapa ambapo ameumwa na nini na mbwa, je, tupashone na weka dressing au vipi? Oh, Eileen Barongo said, don't dress the wound. Okay. Keep those answer coming. Mwingine jibu. We say stay away from the dog, but yeah. Najua watu wengine wanapenda mbwa, so
Absolutely.
yes. So another somebody from Sang said, don't stitch the animal bites. And then Hassan Sairo or Siro Samani from Kilwa Road, the hospital regional. Oh, okay, so that's one unasikilizia kutoka Kilwa. Karibu Hassan. Okay, so 2-3 people said don't dress the wound or don't stitch the animal bites. Oh, Chedil anasema wound dressing, NSAID, I mean like anti-inflammatory, and then give anti-rabies.
Yeah, excellent. Yeah, so we would absolutely want to, those are all perfect answers. So we would want to know if this dog is known to them. Is it a pet or is it, were they taking a walk and it was, somebody else's dog that they've never met before that attacked them? So these are all excellent questions to ask. We definitely want to make sure that they get rabies treatment. And then, as everyone was saying, we don't want to close a bite on a hand or on a foot. We would want to close a dog bite that is greater than 24 hours old, that's on the face. And that is just due to scarring. Because if you leave a face wound open, it's going to scar pretty significantly. But excellent answers. We'd also want to give them some topical. Oh, sorry, go ahead.
Sorry. There's so many responses. Let me just read them quickly so at
Oh,
least
yeah,
everybody
absolutely.
the answer read. So Ms. Solo Kapala said beaten wound should not be stitched. And then oops, don't freeze. And then Antonio Moore says stay away from the dog and visit a high level facility. Ibadi Sharif said dressing the wound, give her anti-rabies and tetanus toxoid, and then antibiotics and analgesia. And then, sorry, a few more. Oh, Antonio Moore from the police dispensary in Arusha. Great. Hassan Shile or Shiley, sorry. Wound dressing, antibiotics, and anti-rabies injections. And then Stephanie Kisaka, dog bite is a serious case, especially if a dog is not well known on a street dog or a street dog. So need very close management, especially social toilets, antibiotics, etc. Veterans officer to be informed as well as check up for signs and symptoms of rabies. Oh, wow. Okay. Good response.
Perfect. Excellent. Yes. And we would also, for this patient, we would also want to perform a detailed neurovascular exam to make sure that their hand is not damaged and that they're going to lose function of their hand, especially because they come greater than 24 hours, they present, they're having significant swelling, which can cause some further damage. And so I just wanted to ask too, what are some common injuries that present to your clinics and emergency rooms?
Sorry, another reason kwamba ni watu wanavyokuja kwenye emergency, vitu ambavyo mnaona ambavyo viko ni vya kawaida au mara nyingi watu wanakuja navyo kwenye emergency ni vitu gani? Yani ni mtu anakuwa na maumia kiasi vipi? Yani kama hiyo unavyosema ya dog bite, au mtu amevunja miguu au ana infection au ni hizo za stroke, mnavyoona kwa kawaida ni ambao mnafanya either kwenye emergency room au kwenye clinics ambazo mnapeleka wagonjwa, mnawaambia waende emergency room. Vitu gani ambavyo mnaviona vinatokea kwa mara nyingi kwenye hospitali zenu? Kama mnaweza anasema Hassan Shile said road accident injuries are common in our facility, more traffic accidents. Dina Kalembe, what is MTA? I'm sorry. Mostly fractures of upper and lower limbs, traumatic brain injury. That's Ronald Paris. Okay. And then Audrey Scott Burns. Dina Kalembe. Oh, motor traffic accidents. So thank you. And Ronald Paris state motor traffic accidents. So I guess those areas that they're busy close to the roads. And
Okay.
motor traffic accident, are you talking about this, like the Bajaj or the motorbikes and stuff like that? Antonio Moore, motor traffic accident, Chidel, motor traffic accident. So there's a lot of. Oh, Ronald Paris is asking again. I'm sorry, I asked before, do dog bite wound get dressed or they have to be left open? I believe she answered, but can you clarify, Ms. Dani?
Yeah, absolutely. So, a dog bite wound on the hands or feet should be left open, but anywhere else, you can close it, especially if it's on the face. You'd want to close that to avoid scarring.
Okay, yes. And Johanna Kibona said, but also should make sure you know the vaccine schedule of the dog so as to opt if the victim needs a vaccine.
Absolutely.
Absolutely. Thank you, Johanna. Okay, so Ms. Anne, you can see majority of the people who are going to the emergency room are motor vehicle accidents.
Yeah, absolutely. So,
Traffic. Yeah, go ahead.
yeah, from what I heard, like motor vehicle accidents, traumatic brain injuries, and burns. That's what I was hearing a lot.
Yes, and some of them, Hagai Kwam has added asthma, and
Okay.
the other is motor vehicle, the same. Okay.
Asthma, perfect. Okay, thank you guys so much. That's super helpful. And so then we can gear our trainings towards those specific areas. Okay, so now we'll move on. Okay, so this patient, you've recently prescribed amoxicillin for your 12-year-old patient. Their mother calls the next day and reports the patient has hives all over their body and wondering if she should give them a dose of an antihistamine. What do you guys think?
So hii nani scenario inasema kwamba ulimpa mgonjwa dawa ambayo I mean antibiotic ama vaccine kwa mtoto ambaye ana miaka 12. Sasa mama yake anasema kwamba kesho yake sasa mama anakuja kuleta kwamba mtoto ana nani hizo hives. Alafu anasema ampe dawa gani hizo ya kuzuia nani hiyo hizo hives. Sasa kija mgonjwa kama huyo unani hapo hospitalini kwenu mnampa nini? Au unataka afanye nini? We'll give him like 30 seconds, probably they're typing. Or
Yeah.
anybody who wants to say something. Chidera Camp, I think he said the hydrocortisone injection. Eileen Barongo said allergic to penicillin. We give antihistamine and steroids. Sorry. First of all, stop the drugs. Very good. Yes,
Excellent. Excellent.
stop the trigger.
So that is exactly correct. So this patient is presenting with a mild allergic reaction. And so all of these scenarios that I presented today, I have seen in my clinical experience. And so you would be so surprised how many people will just continue to take the antibiotic and just, so we have to be telling patients, you got to stop that antibiotic or whatever drug that they have developed an allergy to. Very important that I would want this patient to come in to the clinic or to the emergency room just so we can make sure that their airway is not compromised. Because so quickly, an allergy can turn deadly. And so we'd want to absolutely give a dose of an antihistamine and then some steroids. That's perfect. But then we'd want to absolutely let the patient know, hey, you're allergic to penicillin now. So, and give them a list of medications that they can no longer take. But very important to assess their airway and make sure that they're not experiencing respiratory compromise.
Okay,
Yeah, go
I'm
ahead.
sorry to interrupt. So let me add other comment other people added just to make sure their response is listed. Ronald Price said, I think it might be allergic penicillin, hence should stop the drug. And then Stephen Qhsc said antihistamine like cetirizine and creatine. Boaz Mliwa said stop the penicillin drug, then give cetirizine. And then Gabriel Leber said firstly stop amoxicillin drugs, then find alternative drugs and give antihistamine, preferably hydrocortisone injection, then after steroids if necessary. And then Saulo Kapala said, first of all, stop the drug and give hydrocortisone injection. And then Miss Audrey saying, teaching and observation is important. Mipawa Baya said, anaphylaxis prescription, give antihistamine, example, hydrocortisone injection, tab citizen. Okay, so you can see majority of them know what exactly to do.
Yeah.
So great responses, guys. I just want to make
Absolutely.
sure it's heard. Okay, go ahead.
Perfect. Well, that is the end of the presentation. I just wanted to make this the first one like short and sweet, so we could kind of gauge, what exactly you're seeing in your emergency rooms and what you want to see these presentations be about. I appreciate everyone's reactiveness and responsiveness to all the questions. That really makes the presentation interesting and engaging. Does anyone have any questions or anything that they'd like to discuss now?
I have a lot of questions if you don't have questions. If you guys can share with us to let us know what situation that has happened. If you can share the scenario very quickly, I mean, the type of the um, symptoms or indication that patient shows up, or clinical finding that the patient shows up at your emergency room area, and then what did you do? If you can show up, I mean, you can type it that quickly, that would be great. Or if you can unmute yourself and speak, that would be even better. Because we are trying to see what do you usually do in an emergency situation, and then so we can compare. Now Miss Annie can compare notes with you guys and be able to make sure that future presentation we can direct to what you guys need, like a scenario maybe that has happened before. Any questions, suggestions, something has happened with your clinical experience, if you're willing to share with us, that would be great. Or if you have any question for her, that would be great. So if a stroke patient show up in Tanzania at the clinical, I mean at the emergency room, what is the first thing you do? The patient just show up, the family brought them or something, whoever, the patient show up in the emergency room. What is the first thing you do? If you can type, that'd be great, but if you can speak, that's okay. If you want to say it in Swahili and then we somehow translate for her, that would be great also. Just, we want to hear what exactly do you do. A stroke patient show up in your emergency room or in the hospital. What do you do? We are trying to compare evidence, I mean, best practice from one hospital to another. So we are all learning. So it's okay to share, even if maybe a hospital
Yeah.
that's different from another hospital, that's okay. I mean, then we can learn and see what else do we need to do. Oh, I'm sorry. I missed the responses here. Okay, Amos. So Amason, I'm sorry if I mispronounced your name. Amason Peters, he said primary survey. Ronald Paris, he said primary assessment ABCD while connecting to the monitor and to the monitors for vitals. That's good. What else? Pascal Msuya said assess for airway, breathing, circulation, monitor vital signs. That's Pascal Msuya, Police Dispensary, Arusha. Very good. Hey, from Arusha. Any other person? What do you do with a stroke patient that you would do separate from somebody with other medical issues, maybe diabetes or hypertension? What do you do for a stroke patient other than differently from a medical patient, like a diabetic or hypertensive patient?
Do you use any sort of stroke scale?
Oh, so I was getting there. That's great. Yes. Ask them. Do you guys have a scale to? They also check vital signs. Yes, we know that everybody who comes in the emergency room, you're going to do vital signs. Ronald Paris said yes. So yes to what question? Do you have a stroke scale? He said, yes, we have. We need to know quick management of severe headache, especially with autocorneal dizziness. In case of stroke, it's obvious that there will be a focal neurological deficit level of consciousness. If GCS is less than 8, we need the intubation, connecting the patient to monitor for vital signs and brain scan. Very good. Very good. That's what we want to be able to see if you guys are doing similar things. Anna, do you want to give them just a little rundown roughly for what happens if a stroke patient show up in the emergency room here in the United States?
Yeah. So when a patient presents with stroke-like symptoms, we first do exactly like you guys mentioned, we get their vital signs, hook them up to the monitor, but then we also do a comprehensive stroke scale. And so that includes like a focused neurological exam and then we also get them to the scanner to see um, where exactly the damage has occurred. And if we do know their last known normal, they could be a candidate for an anti-thrombolytic. But then the stroke scale is important too, because we can assess, let's say if they're not candidates for the TPA, then the stroke scale will tell us if their symptoms are getting worse or better, to see if they need to be rescanned, depending on the score. And so we do the stroke scale um, at specific intervals of time. Um, let's see. It's called the Cincinnati Stroke Scale.
Oh, yeah, yeah. So does every other hospital have a stroke scale? Like one of the hospitals, I think somebody from Arusha responded, GCT scale. Do every other hospital also have the stroke scale? Or a tool you use as soon as the patient shows up with those symptoms, you have a way of assessing them. So the person came yesterday, you have the same way. They come today, they come next week. It's going to be similar way of, as long as they present similar symptoms. Do you guys have that? Oh, Boaz Mlima said after vital signs, most of stroke considered to ischemic. So start immediately as aspirin. But if you have access to scan, do it before aspirin to rule out hemorrhagic stroke.
Absolutely.
And then I think there was one person above it. Okay, sorry. We teach them to take aspirin at home onset of symptoms if they know they have stroke risk. Okay, that's good. To have equipment for assessing vital sign is very important to emergency area. Great. And Audrey Scott says anticoagulants. Asia Gamange, I'm sorry. Need to position the patient according to the condition. Okay. Yeah, so those are the things that they do for somebody show up with a stroke.
Okay, excellent, excellent. And that is perfect about, giving the aspirin, but then scanning them first if you're able to rule out a hemorrhagic stroke. Excellent. Would having a designated stroke scale that you can use throughout the hospitalization be something that would be helpful to gauge if their stroke is getting worse or if they're having like secondary strokes?
Audrey said yes.
Okay. Okay. Excellent. Because that is something that we use um in our hospital. And nursing can perform the stroke scale. So that way, if a patient scores higher, then we can, it's pretty accurate in determining that they're maybe having um, a worsening condition. Um, so I would be more than happy to present on that. That's something I'm very familiar with.
In fact, thank you, Miss Anne. Another thing is, are you guys, I think Boaz, oh, you said also if Qhsc is less than 8, put the patient in the left recovery position to prevent aspiration. But if you have access to ventilator, intubate and put the patient to ventilator. So if you guys are using that scale, can any of you send us that, just a sample of it so we can kind of like marry it with what we have here in the United States, just to see what are the things that we do the same, what are the things that we do different, so we can learn from each other. And the next time when she's presenting on the specific scale, so we can use your scale to see what the chronological activities that we need to do to be able to address that part. And then if it's possible, share with the other hospitals to make sure we're, if a stroke patient show up in any emergency room in Tanzania, at least they might get a similar screening, similar assessment, similar treatment. I mean, I know different levels of hospital, I understand that, but the part that the nurse and the doctor can initially do without all these fancy devices, what can we do with just the bare minimum that we can do to save this person or prolong until the actual emergency is addressed? So that's what our goal, to make sure that any emergency area that receive new patients with those similar conditions, we can do at least the bare minimum that can be done to save that person or prolong that person's life. So that's what we can do. If you guys can share that too through the email, I mean, that's the email you receive all these emails. If you can send the email feedback, that would be great that way. And then we can communicate. And I know a number of people, maybe like 4 or 5 people, have sent the email other than just the registration for this course, to say they want to be on the list of follow up with this discussion. So yes, everybody who registered is going to get the follow-up information about this presentation. All these questions that we are collecting from you guys, we're going to put them in there and then send it back so we can share and make sure everybody gets. And I know sometimes the people register, but they cannot attend for one reason or another. I understand that part. But that's why we have all those emails, so we can send out the follow-up. And with those emails, please send us the feedback. What did you would like to see on the future training? Like I know Miss Annie just asked you guys a few minutes ago. We want to be able to tailor for what you want. So all these emergencies we're talking about, we want to be able to say, yes, we're going to focus more of what you guys need, so then we can match with what we have and then try to educate each other and be able to learn for us. Definitely send us that the stroke scale. That would be very helpful. And then we can itemize. So next time we can say we have this patient. If this patient is in America, it's going to get this. And if this patient in Tanzania is going to get this, and then we can learn from each other and see what we can do better next time. So that's great. Oh, Gabriela said, how do we clinically diagnose between hemorrhagic and ischemic CVA? And if it's almost impossible, why do we encourage aspirin while we understand it might be either hemorrhagic or ischemic stroke?
Yeah, that's an excellent question. And there's no way to clinically, without a scan, differentiate between a hemorrhagic or an ischemic stroke. However, hemorrhagic strokes are very rare. More often, the patient is having an ischemic stroke. And so that's why it's safer to give aspirin because the chances of them having a hemorrhagic stroke are less than an ischemic stroke. But great question. And I always, it's very nerve-wracking to think that you're going to give a patient a medication that's going to harm them, potentially harm them. But that's an excellent question. And there's no way for us to differentiate unless we have a scan.
Sometimes the doctors or the physician or a provider at the emergency unit will make the decision at that moment for what they have in front of them. Yes, you might have all these fancy material devices and stuff, but sometimes your brain is always needed because you have to be able to differentiate. Yes, you don't have a scanner maybe to be able to differentiate between the two. However, look at the symptoms of the patient who is presenting in front of you. What are they doing? What could it be? And what is the less things that you can do that you think it may harm the patient? So if you don't have the best scan, so what is the thing that you can do to help this patient? So you do the best you can. And sometimes later on, you might say, oh, I could have done this, but you learn and then you go do better. That's fine. And that's what I said, the emergencies, we're not focusing on all the fancy hospital that have all this stuff that they can do. Sometimes the little things that you can do, I know you guys were saying in the positioning and stuff like that of the patient. Yes, so if you know those things that could help and prolong the safety of the patient, then do them. And that's why we're discussing them now. You can do that part, even if you don't have all those fancy stuff, until the patient gets the best place and the next level of care.
Mm.
Okay. Miss Audrey said when we were in Tanzania, I think she's one of the global volunteer who came to Tanzania last year. She said when we were in Tanzania in the year in ICU in Tanzania, they were very eager to learn new information for their patient. Definitely. Coming to the meeting, the training, we know that, and that's why we are trying to work as hard as we can. Try to address the things that you guys need. And that's why we keep asking you, share what you need so we'll be able to find the expertise who they can come and talk to you and try and answer the question. And of course, we want to learn from you. What exactly do you do best? So then we can integrate what we are doing here. And then Gabriela Labor says, diagnosis between hemorrhagic and ischemic, if it's, oh, this is the same. Oh, Sadie, thank you for the great answer. Okay. Scott, Dina Karembe had no idea. In America, majority present. Oh, majority present in America is ischemic stroke. Okay. I think she was asking somebody else. Welcome, Mary from Bukoba. That's good. Okay, so any other questions? I know we are almost at the end of our time. We're trying to do this training at least an hour to make sure that you guys have enough time to go back and do your stuff. But thank you everybody who shared their knowledge. Samsung is asking, I can give stroke patient with blood pressure 222 over 110 milligram of mercury. What is PR? Oh, sorry, post 80 IV antihypertensive before knowing if it's hemorrhagic.
Yeah, absolutely. Absolutely. Bringing that blood pressure down. However, we want to be careful with rapidly lowering a stroke patient's blood pressure because that can worsen the stroke. So sometimes we will keep the patient's blood pressure on the higher side, like higher than 150 systolically, because we don't want to rapidly lower their blood pressure. But absolutely, giving an IV antihypertensive is safe to do for both hemorrhagic and ischemic stroke patients.
Yes, so I think there's two people said disable the number, don't give antihypertensive, and then another person said, but you must lower this blood pressure slowly. And that's what she just said. Yeah. You don't want to drop it too fast, just slowly. Yeah. That's very good discussion.
Yes. Thank you guys so much for sharing all of your thoughts and discussing with us, and really helps the presentation become more interactive, and we all learn that way.
Yes, we
Well,
do.
Muguzi Annie, I just want to say asante sana.
Asante sana.
No, this was great. Thank you very much, everybody, for coming. And as I said, once we finish in editing or creating this video, we're gonna send it to all the emails that you guys use to register. So that's where you're gonna get the follow-up information. As I said, please send all those scales, send the different scenario that you have met in your clinical area, so we can create another training maybe in a month or so to give you enough time so we can continue this discussion. This was very, very good, and we learned from you guys. So keep sharing. And then again, thank you, Miss Annie, for an exciting and very well-informed presentation. And people are saying from Fernandi, Khalid, thank you for the presentation. Thank you for your good information. Thank you from Tanga, Tanzania. I'm happy with the discussion. Great. So we want you guys to be involved. So next time you come to the meeting, the training, ask those questions. And I said, don't feel shy. If you're shy, you want to write in Swahili, that's okay. We can try to translate as much as we can so the presenter can address your your consent, and we are going to try to keep you informed. And if you put your information in the chat, we are going to include it in the presentation because we want to value your presence and your contribution to this discussion. So thank you very much. We're going to keep going. So let's call this phase 1. So we're going to have phase 2 and 3 and 4 until we address all your questions as much as we can. So again, thank you from Qhsc. As I said, you made the first online training for this year a very successful presentation. So thank you again from Qhsc, from Miss Annie, and from everybody. Thank you. And you want to stop sharing the screen and see if people can come out from there.
Thank you.
There you go. So anybody who wants to come to the screen and say hi. Bye. Okay. Bye, guys. Yes. Thank you.
Bye. Thank you so much.
Yes.
Bye, Audrey.
Bye, Amos. Bye, Saul. Bye, Hassan.
Almost.
Bye, Pastor. Amazon. Yes.